Yes. Yes, Ketan. Please proceed.
Yeah. This is a 47-year-old male patient. I'll be presenting this case of recalcitrant infection in distal tibia and fibula. So before coming to me, this patient had multiple surgeries. So we'll go one by one, and if you agree, we'll discuss at each stage. So it was a distal tibia fibula fracture after a road traffic accident, and the first surgery done by another surgeon. He did open reduction of fibula and MIPO plating for tibia. So this was a fairly good-looking reduction. Does anyone want to comment on the fixation, or should I go ahead?
Please go ahead.
So after this first surgery in February 2020, the fate was like this. After 3 months, the implant had failed. There was a fresh fibula fracture at the proximal end of the fibula plate. Tibia fracture had not united, and the screws loosened and the implant failure. So after this, patient lost faith in the first surgeon and went to the second surgeon. The second surgeon did implant removal and LRS fixation of tibia. Fibula plate was removed, and fibula was the gap was kept there for compression at the tibia, I suppose.
Debridement means what? He had infection.
I don't know, sir. That was what the notes mentioned. He had done debridement and LRS fixation. That was by another surgeon. I was not in the picture till now. So he removed the plate, and maybe he thought the tissues were not looking good, so he did not want to go ahead with internal fixation, and he did LRS. And that's what the patient said. Then, after almost 5 months of LRS, the fracture looked united. Then the LRS was removed, and patient started walking. He was happy, comfortable, pain had reduced. Patient started walking. He was good for almost 3 months, and then suddenly one day he buckled his leg while walking, and he noticed procurvatum deformity. The pain increased, swelling increased, and the X-ray showed a fresh deformity and maybe a subtle tibia refracture at the original fracture site.
Ketan, can you just go back to that LRS X-ray? I want to make a comment over there.
Yes,
now,
sir.
this is what, when we are doing LRS workshops, we always say you have to fit the fixator to the situation and not the other way around. Meaning, just because we only know how to do an LRS and we are not comfortable with the Ilizarov, then you put in LRS in a fragment which is not big enough for the LRS. You notice that third pin from below, it is kind of bent. So
Yes.
it has been put into that fragment and then forced into the clamp of the LRS. So I think this is a big issue in terms of stability. You are not giving adequate stability when we put in an LRS. So this is a sort of thing to underline, that there will be situations where only an Ilizarov will work, and this may be one of those situations.
Yes, sir.
And Mangal say that pin is a thin diameter pin.
Correct. That's why he put it in, because the fat ones would not bend.
Yes.
So the thin diameter, if you put it in, you can bend it into the clamp, is what
But
I think.
For instability. And
So essentially, it is constantly, that pin is trying to straighten out. So it's constantly applying a deforming force, which is not a compression force onto that fragment. So the quality of healing there will be poor.
Yes, sir.
Go on, Ketan.
So after this deformity and a fresh refracture, patient went to yet another surgeon, lost faith in the second surgeon also, and he did like this. He did a formal open reduction, put two plates, one on the medial side, one on the anterior side, put a lot of bone grafts. Fortunately, after this heroic surgery, the wound healed. Patient started walking again. This was the progress from April 2021 to November 2021. Patient was comfortable, he was walking, but the radiological picture was not very good. The fracture was not uniting. Actually, it looks like it was going into a non-union. And in November, patient noticed recurrence of swelling and pain. Till that time, he was asymptomatic for almost 6 months, more than 6 months. And then in January and February, he developed multiple sinuses. The plate broke, implant failed again. It was a frank non-union, and now it was infected non-union. Patient went to yet another surgeon, fourth surgeon, and now this time he was detected as a diabetic, a freshly diagnosed diabetic. So he went to somebody asked him to go to a diabetic foot surgeon. He went to a diabetic foot surgeon. He was given an option of debridement and keeping the implants and saving the limb, and a second option of amputation. So he decided for the first option. And the diabetic foot surgeon or non-orthopedic diabetic foot surgeon, he did something like this. So he just kept the implant as it is, just did the debridement and kept the wound open to heal by secondary intention. Again, fortunately, the wound healed by secondary intention, but the bone had not united. Patient was not very happy with the strength and the weight bearing quality and the gait quality. So he went to fifth surgeon, now an orthopedic surgeon again. And he started on injection teriparatide, gave him brace because it was not very frankly immobile, and considering the multiple surgeries done and the skin condition, he was not ready to operate again. And considering patient not willing for amputation, he just conserved it with brace, teriparatide, and patient was again happy, asymptomatic, walked for 3 months on that. And then developed a second bout of infection where there were again multiple sinuses. Pain increased, swelling increased, and then he visited at this stage to me, and then I intervened from now on. So here, when he visited, patient had these broken plates, the implant had loosened, there was frank non-union, skin condition was not very good, there were multiple sinuses, diabetes was under control. So on admission, we started him on IV antibiotics and regular dressings. So the inflammation subsided. And the second picture is on the day of surgery when I intervened. It's a short video. You can see the frank skin is not very good. Implant is exposed. There was only one incision medially. That one incision, both the plates were placed. But I was very doubtful whether I can remove both those plates from the same medial incision. That's what I did. I removed the plates, fortunately, from the same incision. But the condition of the soft tissue was very bad. The soft tissues were very tight and very hard. Fibrosis was there. I think I did injure anterior tibial artery during implant removal and debridement. But after deflating the tourniquet, the distal limb was vascular. So I just controlled the bleeding with compression dressing. The bleeding stopped. Limb was vascular. Then I applied the Ilizaro rings and did a proximal corticotomy for transport of the middle segment to fill the gap distally. This was the wound. I could not close the skin completely and left it open, but the bone was not exposed. It was just soft tissues in the wound bed. So I left it open and we kept on dressing it regularly. Fortunately, the infection subsided after the implant removal and debridement. Now the swelling was less. There was no infection. And after corticotomy, we started distracting. The corticotomy was done in the second setting after the infection control. Then we started distracting, transporting the middle segment. At the time of docking, there was recurvatum deformity. So we did open docking, corrected. I did open docking, corrected the deformity, applied separate rods to correct the deformity and give compression at the docking site. The contact area improved. And then in the consolidation phase, it went on to heal. Wound also healed gradually with dressing. Corticotomy had consolidated well. And this was during the course of treatment. Patient was mobile. The frame was painless. Patient was walking without support all throughout. after first few weeks of surgery, he started walking without support. Before ring removal, we did clinical testing where I removed all the rods across the docking site. He was walking comfortably. There was no abnormal movement, and patient did not have pain after removing rods also. So I removed the fixator. After ring removal, he had good range of motion. The tibia deformity. Clinical testing where I removed all the rods across the docking site. Joint. He was walking comfortably. There was no abnormal movement. The final X-ray. Patient did not have ring removal. This was the before picture, and this was and the after ring removal. And this is the most recent follow-up after almost 2 years. The tibia has remodeled well. Fracture is united. Skin condition is also improved. His diabetes is under control. He is following the treatment with the physician. So this is it, sir.
Good case, Ketan.
Thank you, sir.
How many interventions you did as soon as you started the illusory surgery till removal of the frame? How many times you had to intervene, add pins and or something like that?
So the first surgery where I did implant removal and the illusory ring fixation in the same setting. After 1 month, after infection control, I did corticotomy. And the third one was open docking and realignment of the distal fragment.
So you had in between.
Ring removal was done without anesthesia.
Yeah. So you had about 3 procedures in between, like changing the wires and all.
Yes, sir.
Yeah.
Control, I did
Purav,
corticotomy.
I
And
mean,
the third one.
extremely difficult case, and you have done a very good job. I also admire
Thank
the
you, madam.
patience of the patient. But
Yes,
I
madam.
just want to make a point for, especially for young surgeons, that if such a case comes to you on day 1, please consider the option of doing Elizaro on day 1. See, it would have united very nicely if Elizaro was done on day 1. So please consider it as an option in such cases.
Yes, sir.
And Ketan, in these cases, many of them may end up with equinus. So that even
Yes,
early, while plating, they must have had some equinus. That equinus is notorious for refracture.
Okay.
So that is one point where even when you do illusory, see that the patient is not having equinus. If at all he is having equinus, make them walk with a high heel. Because
Actually, you have to fix the foot in such cases. Is such low fractures, you have to fix the foot in such cases.
So whenever you're walking, if there is equinus, the mechanical axis actually goes in front of the bone. It comes from the first metatarsal head, not from the heel. When the heel is touching, the mechanical axis goes from the heel. So all loading happens along the mechanical axis.
And basically, once when they are bearing weight in an equinus position, they are giving a recurvatum force onto the fracture.
Yes.
So generally, whenever a joint close to the fracture is stiff, it may not be a bad idea to immobilize that at least for a little while, and then put
Actually,
on
I had
foot.
So,
Sir, actually, I had planned to transfix the ankle joint
onto the fracture.
But during implant
So
removal
generally,
and,
whenever a joint
detecting all those fibrous soft tissues, and I thought I injured anterior artery, though everyone was in a panic mode and to hurry up the surgery. So I just applied the ring and then thought of putting foot ring later. But then patient improved and he denied intervention just to put a foot ring. So during the docking time only, we improvised on the distal fixation and I did not put the foot ring. But actually, I had a plan to put ring, but because of those intraoperative complications, I dropped my plan and finished my surgery hurriedly.
Even in your initial X-rays, there is a fracture is in recurvatum, but you have corrected it without any equinus. your initial X-rays, immediate post-op, there is
Yes,
some
sir.
before that. Yeah, here you can see that there is a recurvatum, and the cut was a bit not 90 degree parallel to each other, and so it was in recurvatum deformity, but you have corrected it nicely without using any foot frame. Anyhow, congrats. Thank you.
But the interesting part is just show me that X-ray. Yeah, just the one before. Now
Yeah,
the rings are parallel.
Yeah.
No,
Which
they
Now
are
they look
they are
parallel.
parallel.
Parallel with recurvatum.
Yeah, no, the earlier one.
The earlier
Which one,
one.
sir?
The
The
earlier
previous slide. Previous slide. Not so.
This
No,
was
only
this was
one
immediate
slide
after
before.
surgery.
Of the
One
frame, of
slide
the
before.
frame.
the frame. Yes.
One slide before. Yes,
Yeah,
here.
you can see the rings are parallel, but there is a recurvatum as
Yeah.
Prasad mentioned.
If you
How
look
do you
at
know
only
that?
if you look at the foot in relation to the distal fragment, you will recognize that there is an equinus there.
Yes.
Yeah, in the next X-ray, next slide, you corrected it. The rings are still parallel.
How you no, they are not very much parallel. There is a
No,
bit
sir.
of
No, sir. Here the rings are not
convergence
parallel. Maybe they are
posteriorly.
looking at the X-rays. I changed the rods to multiplanar hinges across the docking sides, and rings are not parallel here, sir.
Yeah.
So you have done the second surgery here for correcting that, making them parallel.
This was second form open docking with repressioning of the docking
Yeah,
surfaces and then compression across it.
This
he
means
revised the cut. He
Giant.
revised the cut and made it transverse.
Yes.
Yeah.
Ketan,
He is not revealed the trick.
It's not true. And I
The
was
trick is coupled
wondering how this has
washers.
happened. I was wondering how this has happened.
Coupled washers. That's what he has done. Correct, Ketan?
Sir, there are few multiplanar hinges and coupled washers on one rod.
Yeah.
Not all the 4 rods had multiplanar hinges. 2 rods had multiplanar hinges and washers in the other.
Ketan, one thing to point out is whenever we are dealing a fresh fracture versus infected non-union, it is better to have an adequate lever of fixation in a distal fragment. So if we are
Yes, sir.
dealing with infected non-union, then it not only will help in giving adequate stability, but the fixation lever arm would be better. So infected non-union, I would always prefer to have a foot frame in such juxta-articular injuries.
Yes, sir.
Yes.
We'll move to next case.
Yes.
Dr. Ketan, just one question, if the panel allows me.
Yes, please, sir.
Yes, please.
Just wanted to ask you, Dr. Ketan, what is the use of these rubber cocks you have put just in front of every wire? You have put these rubber cocks.
So these are just for the patient's convenience for pin track dressing.
These rubber stoppers are
Just to hold the gauze pieces on the skin.
Sorry, please, tell again.
You wrap the gauze around the wire and then push the rubber stopper
that will
against the
hold
skin so that the wire stays over there. That's what it is.
Okay.
rubber stopper holds the dressing. It prevents skin interference friction.
Okay. Okay.
And it is
Amar, I don't do it now.
yes, sir. I know. It is controversial.
Yeah.
There are
You have to spend time for cleaning the rubber washer also.
Yes, I agree, sir. But it is mentioned in ASAMI books.
I know. Yeah, it is there.
Yes. And
They are useful in first few days, actually. Yeah. Later on, they don't have, and they become so dirty that they itself can transmit infection.
Yes.
There are a lot of things mentioned in the Bible, the Quran, and our Vedas,
yes,
which we don't follow.
Yes, sir.
Thank you. Thank you.
Thank you, sir.
Any question in the chat box, or we move on to the next case?
Dr. Mehul.
Yes, sir. Hello, sir. My screen is visible?
Yes.
Okay, sir. I am presenting a case of infected tibia non-union. Some brief history of the patient. Patient is 18-year male patient, crush injury by machine while working in the factory. He has open grade 3B, proximal third shaft fracture with skin loss over the posterior aspect. Immediate debridement and external fixation done at the government hospital. And when good granulation tissue appears, skin grafting was done by the plastic surgeon. So it is the initial injury photograph, which sees 5 to 7 centimeter of the bone is outside the skin and loss of periosteum. So this is a wound progression. Plastic surgeon did skin graft when good granulation tissue appears. So at time of presentation, after 5 months of the injury, there is a simple proximal third shaft fracture with butterfly fragment, which is fixed by the K-wire and add-on external fixation. But there is some problem list. There is an infection. There is some foul-smelling discharge from the sinus. There is a non-union. There is ankle equinus, is a rigid equinus, and EHL weakness. So it may be 3C injury, in which common peril now may be affected. So my planning is fibula osteotomy, open the fracture site, remove the dead bone and soft tissue debridement, Ilizaro fixation with 4-ring construct and dual corticotomy between R1 and R2 and R3 and R4. This is immediate post-op X-ray, 4-ring construct with dual corticotomy, the equinus correction with percutaneous tenotomy, and there is a 6 centimeter bone gap and 3 centimeter of fibular overlap, which means the total defect is 9 centimeter. The 1.5 month at time of docking. I transport is a single rod. And converted to the segmental rod, and open docking was done and bone graft was put. The 2 months after docking, healing is in progress and fracture site is good callus is seen. This 6 months since index surgery, there is a good regeneration, consolidation, and fracture site healing. So I did dynamization at the both regenerate site. This 7 month post-op, fracture healed and regenerate is well consolidated. At time of removal, there is a clinical photograph and knee range of motion. The wound over the docking site, which healed by the secondary intention. This is a clinical stress test. Patient is walking without connecting rod and without support with plantigrade foot. So this is a fixator removal. There is some valgus deformity at the diaphyseal site. Fracture united, 8 centimeter, regenerate consolidated, wound healed, infection cured, and patient is walking full weight bearing without support, no LLD. External fixation index is 26.25 days per centimeter. And this is a 6 month post fixator removal. The nice healing is seen in the X-ray, and patient is walking nicely with plantigrade foot. So take home message: in such type of open fracture, primary Elizaro will be helpful. It will save the time to the patient. When the defect is more than 8 centimeter, I prefer the trifocal osteosynthesis. It will reduce the time of fixator. And in large gap bone transport, open docking is required. Thank you.
Vasu sir.
Yeah, let us get the very nice case. But your fixated time index was 26 days per centimeter, even after doing 2 corticotomies.
Yes, sir.
So how much you have really saved?
Sir, actually 8 centimeter regeneration is I did. So 8 centimeter
4 plus 4.
4 plus 4, actually 5 plus 3. Actually, proximal side is
Bit
large.
more. Yeah.
So if we do a single monofocal, it will take more time, about
Really
a
saved.
year.
Yeah.
Now,
Now how long it took?
actually 8 centimeter
7 months.
regeneration.
Yeah, it will be taking about roughly about 8 to 9 months.
Okay.
But only it depends upon where the gap is. If the gap is in the middle, you can do trifocal, 2 osteotomies.
Yes.
Suppose the gap is in the distal end, what will you do? You do 2 osteotomies on the upper fragment.
Yes, sir. If in distal more gap around 10 centimeter, I will still prefer tandem trifocal from the proximal side.
So approximately you do 2.
Yes.
Yeah.
It's very good case, Mehul. I just wanted to ask you, how did you correct the equinus?
Sir, ma'am, I did equines correction with percutaneous 3 incision technique and maintain the equines correction with the foot sandal and strap. Patient is wearing this strap whole the day post-operatively.
So you did TLN, fractional TLN.
Yes.
You are not stabilize the foot?
No.
No, in a transport, it's always better to stabilize the foot.
Yes, sir.
Because you are changing the muscle balancing in the leg segment.
Yes, sir.
So that can produce little misbehavior on the foot and ankle.
Yes, nowadays, actually, this is an old case about 2 years back. Nowadays, I fix the calcaneum during the transport period from distal to proximal.
Leg segment.
Yes, sir.
And so that can produce little, seeing them showing the knee range of movement in tibial non-unions and all. So how do you think the knee range of movement is being affected by tibial non-union and Elizaro treatment?
If adequate physio is not done by the patient or is not motivated by the doctors, there is actually positional FFD and equinus can be done.
Yeah, usually the ankle stiffness is a trouble in a tibial non-unions.
Yes.
In the knee stiffness is a trouble of a femur cases. Knee stiffness is more common in femur non-unions and all.
Yes.
Sir, may I ask a question?
Yes.
Dr. Mehul, you suggested doing primary Elizarov in open cases. So I want to ask everyone, like, can we do primary Elizarov in these cases before the wound settles? Because most of the times in gradually the skin margins got necrosed, bone gets exposed. It needs plastic surgery many times. So can we do it on a primary basis, or should we wait for at least 10, 12 days, 2 weeks, so the wound settles and then plastic flaps are given and then we can do Elizarov?
Actually, so may I?
Yeah, please.
Actually, there is difference in Elizaro in primary fracture and non-union. Is the in infected non-union, there is a demarcation of the avascular fragment. Trauma cases, there is no actually demarcation. of the fragment avascular. So you may misjudge the fragment, and maybe it will get infected in future. So yes, definitely this can be done in the primary setting. In primary setting, if we do the acute docking or some shortening around 3 to 4 centimeter, plastic surgeon will not required, and in posterior side, is always skin grafting can be done.
I think Jaideep's question was, should you do an Elizarov on day one when patient comes to you at
Yes.
8 o'clock in the night? I think the answer to that would be yes, you can put in a standard fixator, wait for things to develop. What he was talking about was primary, as in the primary definitive fixation, rather than doing a plate and all. Then once you have got everything clear, then you do the Elizarov.
Yes.
Yes.
And another question, sir, like during the primary debridement, so the bone ends that has no periosteum, do you remove, excise that part of bone, or you wait for some time?
If there's no periosteum, I would take it out. If you believe in what Rajesh says, then you may wait. And then after 2 days or 4 days, when it is obviously dead, then you take it out. But if there's no soft tissue, it's not going to survive. So no point in keeping it.
Okay.
Means whole circumferential peristress stripping is there, and it is not likely to get revascularized whatsoever we hope.
Yes, sir.
Any other question? Shall we proceed to next case?
Yes, Amar.
Dr. Vikash. Dr. Mehul, please stop sharing your screen.
Yes, sir.
May I start, sir?
Yes, please. Dr. Vikash, please share your screen.
Instead of sharing the whole screen, you can just open the PPT in the background and just share the PPT. Then go more smooth. You can just exit sharing, open the PPT, and directly share the PPT. That goes smooth.
Is it visible, sir?
No.
No.
Your home screen is visible, sir. You can open your PPT directly and go live.
I'm starting my PPT. I'm just trying again.
You can just exit screen sharing, open the PPT first, and then directly share the PPT.
Is it visible now?
Not it.
Unshare and open your PPT, then reshare.
Okay, sir. I'm just doing Is it visible now?
No, sir, it's not. Sir, at the bottom of the screen, you'll find a green color box with an arrow on it. Once you click on it, you will find multiple windows which open up. So the screen on which you have your PPT, please click on that. That will open up your PPT. Provided you
working
have,
now?
yeah, now it has. Yes, sir. Please
You
go
go
ahead.
full screen.
Okay. Deepak is a 14-year-old boy when he presented to us. Am I audible?
Yes. Yes.
He has a history of osteoarthritis at the age of 2 years. He advised amputation initially, but meticulous treatment over 2 years, and after 10 surgical procedure, his leg survived, and he was walking like this uh, at the age of 14 years. It may be due to the distal epiphyseal involvement. So there is a progressive shortening and foot deformity. These are the X-rays. May I proceed further, or can we discuss it?
Vikash, how do you go about it? Show the next slide.
Okay. These are the clinical pictures. So it flap and shortening, calcaneus deformity, varus deformity at ankle, subtalar joint fused, jog of movement at the ankle joint, and shortening of foot compared to the other foot. There is a bulgous deformity at proximal tibia, varus and procuratum at mid shaft of tibia. There are two discharging sinus at the lateral aspect of ankle, but one at the flap and other one at the tip of fibula. There is a tibia, talus, and calcaneum are fused, so we consider them as a single unit and realigned the calcaneum to bring the mechanical axis in the line of knee joint. These are the radiographs planning. In AP view, we draw a mechanical axis of tibia and mechanical axis of ankle joint. These are usually at the angle of 2 degree valgus. But here, these are at the angle of 36 degree. So it may show there is a varus deformity at subtalar joint of 36 degree. In lateral radiograph and planning, we draw mechanical axis of tibia and calcaneum. These are usually at the angle of 60 degree, but here these are parallel. So there is a deformity of 60 degree at the subtalar joint. These are the other axis in planning. When we draw the axis of first metatarsal and the tibia, we found there is a deformity of 31 degree of dorsiflexion. When we calculate it, we found that cora at the subtalar joint with the recurvatum at the varus deformity of 64 degree. We planned for Elizaro. We planned Elizaro in 3 functional units. First is the reference unit, in which we mount a Elizaro at leg and talus included in this. Other one is calcaneum unit to correct the calcaneum deformity. And third is midfoot and forefoot deformity unit, for which we correct the forefoot deformity of equinus. Dorsiflexion. I used Lizaro frame of 180 degree size, 180 size of Lizaro rings, because foot deformity frame is so complex to accommodate the complex foot. After applying this frame, first we did a calcaneum osteotomy, then we did a fibula osteotomy, and 2 ring tibia frame mount. On this tibia frame, we mount a prefabricated calcaneus frame. You can appreciate this frame in distal tibia and calcaneum. Calcaneum below the osteotomy, we use 3 wire and 1 shunt screw in osteotomized calcaneum. Final osteotomy done in proximal tibia to gain length. After which we apply 2 static rings in forefoot to correct the forefoot deformity of dorsiflexion later. These are fixed to the static rings of tibia. These are the fluoroscopic image, shows the ring mount on the deformity, and the center of the rings, which are the bolt, at the level of deformity, and the hinges at the behind the calcaneum. It may be a dissection osteotomy, and angle from the calcaneum is around 25 degrees. Correction sequence started. Dissection started after 3 days for 1 mm per day. Proximal tibial lengthening started after 5 days with the rate of 1 mm per day in 4 times a day. Forefoot correction initiated after a hindfoot correction. These are the dissection unit of forefoot correction, and these are the dissection unit for the tibial lengthening. Then progression started, and we disconnect the tibia of calcaneal ring and modified it to accommodate the foot. The graduation of the correction. Then we, after the complete correction of calcaneum, we convert the static ring to correct the dorsiflexion of the foot. Some complication I encountered in this process. First is premature consolidation of fibula. We manage it with the regional fibula osteotomy. Another complication is early consolidation of proximal tibia regenerate. We to solve this problem, we increase that dissection by the 1.5 mm per day. But after increase the dissection rate, developed that there is some FFD at knee joint and numbness at distal leg and toes. So to manage it, we slow the dissection alternate day at the 1 mm per day and alternate day 1.5 mm per day. Oral medication started for pregnenolone and methylcobalamin combinations. These are the clinical photo. After complete correction, we can appreciate the fixed flexion deformity at the knee joint. Further flexion possible at this site, at this stage. Just before funeral, when I get full length of the leg and full correction of the deformity, we plan to remove the frame. A kid was walking comfortably on the frame. 2 months follow, he is walking comfortably. There is some residual varus, but length was gained. These are the X-ray, so good alignment of the calcaneum in reference of knee joint and the proximal tibia. We can not appreciate the true AP view in this X-rays. Ankle fusion plan to complete the deformity and achieve the complete arthrodesis at the ankle joint. We plan for dissection compression, but after the complete correction, we can appreciate that fracture is usually fracture was united. Family for the foot lengthening, family don't opt lengthening by the laser. We can opt to lengthen them. Thank you. Any questions?
So the final X-ray.
These are the final X-rays.
Why you have not done any correction at the lower third tibia instead of bringing it forward? Another catechism and then correction of angulation procurvatum at the lower third tibia.
Sir, I suppose that if ankle joint and the subtalar joint fuse, then tip of the calcaneum, if I realign the calcaneum to the knee joint, it will restore the gait and the axis of the whole leg below the knee joint.
Vikash, Is it a primary tibial deformity or a
Yes, sir.
primary foot deformity?
Yes, sir.
Is it a primary tibial deformity or is
Sir,
it a foot deformity?
Sir, it was a complex deformity, including tibia and foot also.
No, you have to actually differentiate between how much is the tibial deformity, how much is the ankle deformity, how much is the forefoot deformity.
Sir, I basically calculate all the deformities, and
Yeah.
I found that if I
This is a gross
correct
analysis
all
only.
the deformities,
Yeah,
I
there
have
is a
to.
there is a
Yes, sir.
inflection of the ankle and fused. There's a cavus. There's a recurvatum distal tibia. There's a procurvatum proximal. Distal third tibia. You could have corrected
Okay.
all these three, everything, no?
Sir, yes,
Why
sir.
didn't you correct the
If you calculate yes, I calculate the deformity at the distal aspect and realigned it to the proximal one.
So you neglected the tibial deformity.
If ankle joint and subtalar. Yes,
No,
sir.
by correcting that deformity, the tibia, you will automatically get some length and alignment.
Yes, sir.
Yeah,
Yes, sir,
even
I
I
can
feel
get,
the
but
plan should
the
have been
axis
to
of the
correct the tibial deformity first.
Yeah.
Yeah, so that was the primary deformity.
Yeah, then we have a base on which your foot can be corrected.
Yes.
Now, for some reason, if the patient develops a fracture in the distal tibia, how will we manage?
Yes, sir. Again, is also. That's why I'm asking that if alignment was corrected and axis of the leg, so the fracture united very well. And by the 5-year follow-up, he is doing very well. He has no complaints.
Do you have any follow-up X-ray 5 years? Because
no, sir, he is not coming.
there is a possibility of remodeling, but there is the weight loading is transmitted onto the anterior aspect of the talus, and which may not be able to do well.
Sir, there is no talus and calcaneum. There is a single bone. That is pterocalcaneum, which is ankylosed and fused. And the axis passes to the original where we can, which should be passed. Weight bearing is normally.
Okay, do you have 5 years follow-up X-ray? This what you are showing is the same?
No, sir. He is not coming, sir.
No.
He just talked me on phone. And me.
Right.
Dr. Vikash, there is one question. Instead of separate calcaneus and foot ring, they are separate in your case. Could you have used a single foot ring including calcaneus and forefoot? Because you have not done an osteotomy between these two elements. So would that make the work easier?
Yes, it makes work easier. But at the time of planning, I think it is the complex situation. What will be happen after the complete correction of the calcaneum? And if it needs the osteotomy after the complete correction of the calcaneum, I wish to did at the level of the proximal midfoot level to correct the to realign it.
Okay.
Because sir, I have a question.
Yes, sir.
If you want to do ankle fusion, so why
Yes, sir.
you want to do ankle fusion now? Or
I wish to do, but it already happened.
So
without any.
Primarily cut the tibia and ankle fusion and in desired position of the foot. Can it be a good idea?
It may be, but I have to reduce all the possibilities, and we should do as in single stage.
Dr. Vikash, can you show your frame how the hinges work?
Yes. These are the same construct. These are the hinges which are at the level of fora.
Okay.
And destruction started from here.
Where is the distraction rod?
The 4-foot rings. Yeah, this one. It is the 14 upward sky. This one.
Okay, there is a lag in your network. Probably
one.
network is slow. Yeah, I'm not able to see your cursor.
Yes.
So
Can you appreciate now?
Is it dorsally the distractor on the
Yes,
dorsal aspect?
Yes, actually dorsal medially.
Okay. So one distractor and one couple of hinges. Is that right?
Yes, one distractor with the same situation. We can the oblique from tibia. I can't for the patient.
Okay.
Dr. Vikas?
Yes, sir.
Taran is here. Dr. Vikas, what about your proximal ring at proximal tibia region at corticotomy? I think the ring size is much wider than required.
Yes,
Do
sir.
you agree with that?
Used. Yes, I agree. I planned it to a larger size to accommodate the complex foot deformity. In the lower sizes, it was difficult for me. I planned it for 3 or 4 days. Then I found this solution. Okay.
Yes, can you see this?
Yeah, sure, not properly. Sir, it is blurred image.
Yeah.
Sir, you have used a blurred image background.
No,
That is the reason we are not able
iPad
to
is not
see.
coming there. I'm just showing on the iPad. I think maybe I have to make a PowerPoint. You can actually get the good result by at the ankle level osteotomy and the distal tibial osteotomy, get a good correction. So it looks neat and straight. And dimple in the front of the knee ankle, no, that also will be corrected by that. And your job should have been much more easier, and you should have got good sleep. With this foot frame, you must have had real tough time.
No, sir, it was comfortable.
No, you have to change so many times the hinges and all, no. The foot frame has to be changed. The connection was below, then you have to take it to the top. You don't need any of these things to correct it.
Sir, you can share your iPad screen, sir. Vasu, sir. You can share your iPad screen so everybody can see and learn, sir.
iPad screen?
Sir, via Zoom, sir.
No, it's not possible, no?
I have an exactly similar case. Can I share my screen if the seniors allow?
Yes, please.
Is my presentation visible?
Yes, sir. Visible.
Okay, so he had an injury to distal tibial physis in childhood, varus and recurvatum. Exactly, I think not exactly, but quite resembling case. So he's walking on lateral border of foot, the child. And I planned a distal tibial osteotomy and upper osteotomy for proximal tibial valgus correction. That's my tracing. Did with ortho SUV, supramalleolar osteotomy. That is the correction at supramalleolar osteotomy. Nothing has been done to hind foot or forefoot. And that is the result. So I have left the cavus. I have not done cavus because the work would be too complex otherwise. And that is the before surgery and after surgery pictures. Still, there is some remaining varus, but I think the boy is better than pre-op.
But your core is at the upper level of the neck, supramalleolar area.
Yes, cora is
and
at
I found
supramalleolar.
cora at the cranium.
Yes.
Yes, my cora is at the subtalar.
Because can you see this now?
Yes, sir.
Can you see that frame?
Yes, sir.
Yes, sir. I planned it. Yeah. Yes, sir. I planned it.
Recording stopped.
And it required more osteotomies, etc.
2 osteotomies only, no?
Yes. 2 more osteotomies.
I have not done any foot osteotomy.
Yes, sir.
Because it's a difficult deformity.
Now foot is in equinus.
Foot is cavus. That you can substitute.
Overall, for these kind of difficult fractures, you can take a simpler approach, where what you have achieved right now is the foot is plantigrade when the patient is walking. The plantar surface of the foot is perpendicular to the proximal part of the tibia. So what everybody is pointing out is that could well have been done by using just a foot plate on the foot, doing an osteotomy somewhere in the distal tibia, and then get that plantar surface properly aligned in relation to the proximal tibia, so that patient is able to walk.
He is also having a cavus foot. Actually, even that has to be corrected by some V osteotomy or something like at the mid-metatarsal level.
Maybe
if it is properly aligned.
It can get it through soft tissue.
Yeah.
You can just pull it up. It will come because there is no fusion there.
Yes, maybe.
Yes, good session, Amar. Good participation.
Thank you, sir. Thank you, everyone. And I'll ask
that Mangal could join from Ramnagar.
Yes, sir.
Have you started already?
Mangal, sir.
So otherwise you won't get good connectivity anywhere.
Yes, yes.
I must congratulate the presenters. All cases were really good. They were difficult and good learning.
And there is no other option other than illusory in such cases.
Yes, absolutely.
The indications.
Yes.
Dr. Samsul, please have some announcement about your midterm meet.
Thanks, Dr. Amar.
Yes.
So thank you all for wonderful cases. I again request everybody. You can see my screen, Dr. Amar. Can you see my screen?
Yes.
So I invite you all for our upcoming ASAMI midterm meet at Patna on 12th or 13th of July. We have got around 50 registrations yet, and we are doing it organized by ASAMI India and the agencies of Bihar Orthopaedic Association. John sir is helping us. The highlights of the program, we see that the theme is all around knee, all around knee. So it's a very good symposium theme based for the first time on behalf of ASAMI India in Patna. So the highlights are we are doing hands-on workshop on many things like we are doing out STO, we are doing out TCVO, we are doing out DA4. This will be by our eminent faculties, and the sites will be having demo workshops on knee arthrodesis, knee contraction, knee particular. So it's a full workshop based and very interactive. We're having less lectures and more of interesting cases. We have PG quiz, we have 3 page papers, and just we did a wonderful faculty development program initiated by Dr. Siddhartha at Chandigarh. We're doing the same. We are having a 2-hour session. We are inviting all our participants, faculties to share their cases on our email, that is asami.patna@gmail.com. You can contact Dr. Ritesh Pandey, who is taking care of all the scientific program. And for anything else, you can contact me or Dr. Ashutosh from IGMS or Dr. Vikash, who is coordinating. We're doing it at Lemon Tree, is a very nice hotel, just around 15 minutes from airport. We have a very new airport, Patna, now inaugurated by PM Modi sir. It's a very nice airport. And besides, we have our eminent national faculty, our President Mangal sir, Amar, Dr. Muslim, Dr. Rajat sir, RS sir, Dr. Ravi Chauhan, Milind sir, Manish sir, Vasudevan sir, Prasad sir, Rohila sir, we have Amiya sir, we have Saki Das sir, we have Tibia sir, Dr. Jijesh, Dr. Pritesh, Dr. Jindra, Mojindra, Dr. Subramanian Gandhi, Dr. Pranav, Dr. Jaydeep, Verma Karthik, and Shani and Akansha. Nationally, John sir is heading the program, and Ritesh taking care from AIMS, Ashutosh taking from IGMS. We have all the institutional support from here. Dr. Vikas will be coordinating for the program. We have the whole support of BAA, our President Upendra sir, our dynamic President-elect Amar sir is helping a lot, Kevin South sir is helping. Chha sir will be our patron. Other faculties from Patna, we have Dr. Jaswinder, Dr. Janki, Dr. Ritesh, and many others. Besides the scientific program, if a few people are ready from 10 to 20, we'll having a program at Rajgir Zoo Safari. It's a very truly international level, very developed. Shall be expecting messages from persons who are interested in coming to see the Zoo Safari one day before on 11th. We have to make a schedule. All the arrangements will be made from my side, from our Patna side. So it's a very nice program. You can just attend the program. Just inform that I want to attend. Because Mangal sir is a very zoo-friendly sir, so I request Mangal sir to come before, that's one day before. We done a good very photography at Zoo Safari. We have so many tigers and lions over there.
Which safari was that?
Sir, Rajgir Zoo Safari, sir. It's a very nice one.
Zoo
Safari, exactly, sir.
Okay.
It's a very good one, sir. Truly international. It's recently developed. It's a very good one, sir. We'll be having Innova as well as minibus for the delegates. I'll send the videos for the same in the group, sir. Regarding the registration, we have extended the early bird till 15 June. These are the 7,000 for the ASAMI members, the delegates and faculties. For the international, we have 8,000. For the PGs, we have a fixed 5,000 for everybody. For residential, everybody can contact me or the hotel manager. We have, the room charges is around 7,000 for each plus tax and 8,000 plus sharing. So that if somebody wants to do sharing, it can be 4,000 plus tax. For anything else, you can contact me anytime. These are the bank details. We are using the ORF, that is John Sir's institution, account for the same. We have the registration link all in the groups to everybody. So with folded hands, I'm inviting everybody who are not registered yet to register. Just need support from ASAMI side. And besides, I'll be requesting our secretary, Dr. Amar, to say a few words about the program.
Shamsul, I have already registered. What is the registration status now?
Sir, it's around 50, sir.
Only that much?
Yes, sir. Local registration are still pending. So we'll be getting more from more PGs from Bihar, sir. Okay. In another 15 days. So that's around 75 to 100, sir.
So I posted in most of our group also, and I request all others to post in respective group regarding this midterm meet. And I urge all young orthopedic surgeons to join this meet. it would be worth attending because it is a theme based and all national faculties would be there. And I wish Shamsul a great success in this meet.
Thank you so much.
Thank you.
Thank you.
Thank you. So, should we finish now? Any question in chat box? No. I thank everyone for joining this meet, and all senior doctors, moderators, and delegates and presenter. Thank you, everyone.
Thank you, sir.
Thank you.
We'll end the session now, sir.
Yes, please.